Good afternoon. You are on the channel of Doctor of Medical Sciences, Oncosurgeon Professor Sergey Nikolaevich Pashchenko. On my channel, you can get acquainted with modern trends in the field of cancer prevention, cancer diagnostics, treatment of malignant neoplasms. Today we will talk about the errors of morphological diagnostics of cancer. Patients often come to an appointment and ask, "Doctor, do I really have cancer?" Here I want to answer you right away. The most important diagnostic criterion associated with the diagnosis of a malignant tumor is morphological diagnostics, the study of diagnostics. This is very important because at present the arsenal of morphological methods has expanded significantly. Immunohistochemical methods have appeared. These methods are methods of refined diagnostics. The main diagnosis is the histological picture that the enemy pathologist sees. Currently, there are detection errors and interpretation errors. What is a detection error? A small tumor a few millimeters in size and all the material is not from the tumor, but from the nearby surrounding tissue. Naturally, this will be a detection error. In a small percentage of cases, there are interpretation errors when the doctor looks through a microscope and incorrectly evaluates the histological picture of the formation. That is why it is very important when diagnosing a malignant tumor to have several pathologists examine the preparations. Then the likelihood of error is significantly reduced. The next error is underestimation of the histological structure of the tumor in terms of reflecting its malignancy. Are quite heterogeneous, have a different tendency to metal, radiation therapy, different ability to metastasize hematogenously, or lymphogenous lymph nodes. That is why it is very important to evaluate the morphological criteria that are characteristic of malignant tumor spread, because there are malignant tumors that grow locally, destroying tissues with a low tendency to spread. In addition, tumors are usually weakly sensitive to chemotherapy. Patients often ask whether it is possible to predict metastasis, sensitivity to chemotherapy, hormone therapy, and targeted therapy based on the structure of the tumor. Often, pathologists in their reports do not provide the necessary clues associated with the structural features of the tumor, which, as a rule, correlate with the ability to form metastases. If the preparation a lot of dividing cells, naturally the sensitivity to chemotherapy will be high, or vice versa, highly differentiated cells, slightly different from healthy cells. In this case, increased sensitivity to hormone therapy is possible. That is, when assessing the histological structure of the tumor, it is very important to predict the course of the tumor process. This, of course, should be reflected in the conclusion. Currently, in many countries of the world, the problem of cancer is being commercialized. This is a negative trend. I am not a supporter of business in oncology. This is primarily due to the extreme complexity of this problem. Currently, immunohistochemical research methods are widely used in almost all countries of the world, which, as a rule, are introduced into protocols, diagnostic protocols. This is a serious mistake, because the immunohistochemical method is not a diagnostic method. The immunohistochemical method is used as a method of refined diagnosis. With his help, it is possible to clarify the nature of the tumor process, determine the sensitivity of treatment methods, the possibility of tumor spread. That is why it is a serious mistake when a doctor expects an immunohistochemical method, having in conclusion, the fact is that when a histological examination of preparations is performed, as a rule, a trephine biopsy is performed. A section of the tumor is taken and is sent for a pathological examination. And if the immunohistochemical method, this method of refined diagnostics, is delayed, then naturally the patient remains for a considerable time without treatment. In principle, trypanobiopsy is a fairly safe research method, but with long-term, in a state where no treatment is carried out after trephine biopsy, a paradoxical situation arises. There is inflammation in the tumor, and hypoxia increases in the tumor. Hypoxia is a lack of oxygen. Under these conditions, the progression of tumor cells increases, and malignant clones may appear, which are associated with metastatic processes in the long-term period. That is why after trypanobiopsy it is important to start treatment methods. And as for the immunohistochemical method, as a method of refined diagnosis, here it can be used in relation to personification and individualization of the treatment method after receiving the conclusion. One of the serious difficulties and errors of morphological diagnosis is the diagnosis of in situ cancer. Patients often ask the question, do I have precancer or cancer? This is especially true for small tumors. What is the problem? In situ carcinoma, the tissue structure is preserved when tumor cells cannot break through the basement membrane. The basement membrane, and spread through the circulatory system, through the lymphatic system. That is, it is cancer in itself, it does not spread throughout the body. And when a pathologist diagnoses the nature of the tumor process by histological method, he must make sections. And there is an intermediate form. In situ carcinomas can turn into microinvasive carcinomas. Moreover, microinvasion can reach several millimeters. And imagine a section is made, and the microinvasion is not included in the preparation. It is with these errors of histological diagnostics that are associated. Those negative cases when in situ carcinomas, patients have distant metastases. This is a very small percentage of patients. According to some data from some clinics, this is 1%. Other clinics indicates a 2% risk. There is data indicating that the metastatic process develops in 3% of cases. The next error in morphological diagnostics of malignant neoplasms is insufficient. Insufficiently clear diagnostics, insufficiently professional assessment of regional lymph nodes. Here we have several groups of errors. First, few lymph nodes are examined. The lymphatic system is complex, and the lymph flow is not always stepwise. Therefore, it is very important to decide, in choosing the number of lymph nodes to be examined, and in those cases where the number of lymph nodes is small, detection errors occur. The next group of errors associated with the diagnosis of lymph nodes in patients with malignant tumors is the detection of micrometastasis. Micrometastases in the lymph nodes can be several millimeters or even smaller, and they may not be included in the section, and thus the micrometastasis is not diagnosed. Therefore, when assessing regional lymph nodes before surgery, it is very important to assess the lymph drainage pathways using ultrasound, positron emission tomography, which will tell the pathologist the features of the section study when diagnosing regional lymph nodes. In addition, when diagnosing micrometastases, immunohistochemical methods of research are extremely effective, with the help of which it is possible to quite clearly identify the structure of the lymph nodes. And quite a common mistake of the pathologist anatomist when lymph node response. This is a serious mistake because the lymph node contains cells that protect the body from malignant cells, and therefore, when characterizing the structure of the lymph node, it is possible to predict the course of the tumor process and therefore individualize chemotherapy, radiation therapy. Patients often ask the question whether to conduct or not to conduct non-radiation therapy, whether it makes sense. To conduct chemotherapy or not to conduct, does it make sense? So, an assessment of the structural components of regional lymph nodes allows us to answer this question more accurately. It must be said that errors in the diagnosis of malignant neoplasms are most often associated with an insufficiently clear understanding. Doctors' features of cancer diagnostics of patients with malignant neoplasms. That's why I posted a lecture on my Patreon page, a large lecture dedicated to diagnostic methods in oncology. For doctors who are interested in this problem, for relatives of patients, for patients who need to know the capabilities of this or that method. I talk in more detail about the features of cancer diagnostics. This is very important because there are often, especially recently, when they try to establish a cancer diagnosis using genetic diagnostics. I repeat once again, the main factor in cancer diagnostics is histological examination, which is the foundation of morphological examination, because morphological examination also includes a description of the tumor. This is very important for prognosticating treatment, for planning treatment. Often, surgeons do not describe the structure of the tumor clearly enough after surgery. And this is important for the individualization of treatment. That is why in my lecture, which is devoted to modern methods of diagnosing malignant neoplasms, which is posted Lectures on Oncology on Patreon, I give a detailed description of the feasibility of combining methods and the capabilities of this or that research method. Because the use of a research method, in particular a genetic diagnostic method as a separate research method, is not correct and is of a commercial nature. The same applies to immunohistological research, which is, as I have already said, an auxiliary research method. The next mistake concerns cytological research method. What is the essence of the error? Here is the cytological method. With the help of this method, it is possible to evaluate the structure of cells. It does not provide characteristics of the entire tissue component. This significantly reduces the possibilities of cytological diagnostics. This is especially true for squamous cell carcinomas and especially thyroid cancer. There are many cases when the cytological conclusion is squamous tumor, and then squamous cell. After the planned wiring, it turns out that this is a benign tumor. The cytological method is quite inaccurate. And how to increase its accuracy, I talk about my lecture on the problems of morphology in oncology. This is a lecture on carcinogenesis, and the second lecture on the diagnosis of malignant neoplasms. There is lecture material. I am now posting it in full on Patreon, and the subscribers of my YouTube page. It's called Current Issues of Modern Oncology. They receive messages about the next lectures devoted to the prevention, diagnosis, and treatment of cancer. I will dedicate the next lecture to the problem of errors associated with laboratory research methods in oncology. Subscribers who are subscribed to my page, they will receive a message when I post this lecture. Thank you for your attention. Good health to all of you. Goodbye.